So my first article is on aggressive or moderate fluid resuscitation in acute pancreatitis, which is published in NEGM. So there was this randomization of the patients that were taken into account and of pancreatitis, and they were subdivided into patients receiving aggressive fluid resuscitation and moderate fluid resuscitation. So aggressive fluid resuscitation received bolus fluid of around 20 ml per kg to start with, and then infusion of around 3 ml per kg per hour. And the checkpoint at the end of 3 hours or later on at the end of 12 hours, 24 hours, 48 hours, and 72 hours. These were the checkpoints. So the checkpoint or the safety point was fluid overload. So in the aggressive fluid resuscitation, it was at around 20 ml per kg, followed by 3 ml per kg per hour. Whereas in the moderate fluid resuscitation, it was they started with 1.5 ml per kg per hour. They started with bolus of 10 ml per kg, followed by infusion of 1.5 ml per kg per hour. So the goal-directed therapy checkpoints were differentiated if the patient is hypovolemic or normovolemic, or there was suspicion of fluid overload. Then accordingly, then they decided to decrease or stop the infusion of the fluids. So this was their fluid resuscitation protocol that they followed. So the safety outcomes in these cases, we can see that they looked over clinically and radiologically. Signs were seen in terms of dyspnea, in terms of peripheral edema, pulmonary rals, increased JVP, or in cases of imaging as signs of heart failure on echo, on imaging radiographically, pulmonary congestion was noted. So there was an increased percentage in this aggressive fluid resuscitation group, where you can compare and see that fluid overload signs, there was this 20.5% increase compared to the 6.3% in moderate fluid resuscitation group. Even in different signs of fluid overload or evidence of fluid overload, there was increase in the percentage in aggressive fluid resuscitation group compared to the moderate group. So the results that they found was that fluid overload developed in 20.5% of the patients who received the aggressive resuscitation, and in 6.3% of those who received moderate resuscitation. The median duration of hospitalization was around 6 days in the aggressive resuscitation group and around 5 days in the moderate resuscitation group. So they concluded as in this randomized trial involving these patients with acute pancreatitis, early aggressive fluid resuscitation resulted in a higher incidence of fluid overload without improvement in any clinical outcomes. Over to you, sir.
So, again, yeah, this was a very landmark paper. As we know from right from beginning in pancreatitis, acute pancreatitis, we tend to infuse more and more fluid, which is not a good practice, as this paper rightly said. And the most important, the patient who are hypovolemic, we should give the bolus dose. If the patient is 10 ml per kg, 10 ml over per kg over 2 hours, and if the patient is not hypovolemic, we can start direct 1.5 ml per kg per hour infusion. So that's what the very important notice. Although the study has the primary endpoint of to decrease the severity, but after this interim analysis, they found that there was no as much difference, significant difference. But yes, there was high complication, high volume overload in patients who were aggressively treated. Yeah. So any comment, Dr. Mayado sir?
Yeah, I think this study is very important because how much fluid to give in an acute necrotizing pancreatitis has always been a debate. In fact, it has been traditionally taught that acute pancreatitis is like a big retroperitoneal burn because of which there's a lot of sequestration of fluids. So you need to pump in the fluids, and there is always a debate. However, practice has always taught us than trying to pump in too much of fluid. And this study now puts a stamp on that. And it's extremely important for all physicians to practice it, because unnecessarily pumping too much of fluid is not the right approach. And in general, we have been taught that if the patient is not having any cardiac abnormalities, any issues related to old age, in acute necrotizing pancreatitis, it is ideal to maintain a fluid resuscitation of anywhere between 100 to 150 drops per minute of that rate. And if that you keep and you continue that, and I think you can, then I think it goes well. So this is my take on it. So it's a very important study
Significantly,
by which all
yeah,
patients who are now treated for acute neck, yeah, very significant. Yeah.
yeah.
Yes,
It's
Chetan, you
significantly
want to say
change
something?
objectives also. Yeah, Dr. Chetan, sir.
Yeah, as Amit rightly said, pancreatitis, that is mainly severe acute necrotizing pancreatitis with organ failure, there's always a dilemma of giving fluids. And the pancreatic group from Mayo Clinic, led by Dr. Santiswarup Rege, they always advocated 5 to 7 liters of fluid in first 24 hours and mainly ringerlected in the first 24 hours. But I think this is changing now. Now with a more understanding of the physiology and also pathophysiology of pancreatitis, I think the moderate amount of fluid in presence of hypovolemia, systolic BP less than 90, or creatinine about 1.9 to 2, you can give about 10 ml to start with per kg per hour, and then 1.5 ml per kg per hour you can continue. That comes to about 3 to 4 liters in first about 12 hours, and which is good enough for everything. If you give more fluid, then the pulmonary conditions and the most common causes of like alcoholic pancreatitis or a systemic disease with diabetes will be always cardiorespiratory compromise. So it's better to give a moderate fluid than a severe fluid.
Yes, sir.
So
Absolutely
open.
true. I think it's the right paper. Yeah, yeah.
So this was a multi-center study, and one of the India center was also involved in this study. So from Surat, yeah.
And
Dr.
mainly
Mehul?
they talk about a ringer lactate. The fluid they talk about a
Yes.
ringer lactate. If there is a presence of peripheral acidosis or lactic acidosis, the ringer lactate is the preferred liquid, intravenous fluid.
Yes. Dr. Mehul?
Yeah, hi. I think I have nothing more to add. I think both the bosses have said it very clearly. And I think there is an article which is very simply putting it forward that nowadays, in a lot of critical care, we have started coming down and using fluid very judiciously. So this initial resuscitation phase and then the de-resuscitation phase is something what we have started realizing, because that is something where we need to be clear that in critical care, no more there is a role of just keeping fluid blanketly at 100 ml to 200 ml per hour and then readdressing that question after you land up getting a cumulative positive balance. So in our ICUs, if you see, we will always have on our monitors and in our sheets something called as a cumulative positive balance. And that is something what we tend to tell all our doctors to ensure that that is not going at least more than 10 ml per kg of body weight. So this is a very good, important paper. And I think the bosses have said it very rightly.
So the next paper is a meta-analysis regarding early versus delayed interventions in case of necrotizing pancreatitis. The objectives were that usually the interventions are generally postponed until 4 weeks after the onset of acute pancreatitis. But there always remained a controversy about whether we should wait for more than 4 weeks or can intervene early when necessary. So this meta-analysis was conducted to look at the outcomes of these patients according to the cutoff defined in the revised Atlanta classification. That's less than equal to 4 weeks or more than 4 weeks. So in this, the results that they found out in 11 retrospective studies, which included 775 patients with early interventions and 725 patients with delayed interventions. So patients with early interventions tended to be complicated by organ failure. The rate of adverse events were comparable, but the rate of mortality was significantly higher in early interventions. So technically, the success rates were similar, but the clinical success rates tended to be low in early interventions, though not statistically significant. So they concluded that early interventions for necrotizing pancreatitis were associated with higher mortality rates and did not reduce adverse events or improve clinical success. However, the results should be confirmed in prospective studies.
So I guess with this, I'll take over with that. But sir, if I can take you in on this, sir, and your expert opinions on this, because there has always been this thing whether should we go in and intervene early. We've always been taught in critical care that it's always better to delay as much as you can, and we've never been able to get the right time or the right moment. Ultimately, I think the only interventions that we tend to be pushed to do is when the patients are landing up having unexplained fevers, large collections, and they're getting a little hemodynamically unstable. So what is your take on the duration of the timing of intervention, sir?
Yeah, see, Mehul, acute necrotizing pancreatitis, moderate to severe pancreatitis necrosis with peripancreatic collections. The revised Atlanta classification in 2012 has given all different terminology, and the words like intrapancreatic or acute pancreatic cirrhosis to pancreatic abscess, all those have been removed. And the only four things have been put. The first 1 week and after first 1 week. The first 1 week is supposed to be most critical because multiple organ failure takes place and ARDS sets in and patient requires ICU and maybe ventilator support in some number of cases. Acute necrotizing pancreatitis, you see about 20% of cases in the clinical practice, which requires multi-modality, multi-speciality approach. All these things, all these studies have two basic problems. One problem is the number of cases, number one. And two, it was basically retrospective analysis. So we need definitely prospective study on all these things. But what has changed in last about 10 years is aggressive percutaneous radiological approach and aggressive endoscopic approach also. So between 1 to 4 weeks, people talk about surgery after 4 weeks, but 1 to 4 weeks, if the patient is not stable, patient has got severe infection, we have option of aggressive endoscopic treatment, LAMS, which Amit does regularly. Amit will talk about that. Even the percutaneously, the radiological drainage, when there are other complications where endoscopy is not indicated at that particular time. But I will still say that, when we were practicing in the initial stage, we were going in first week or second week aggressively, we were going in the surgery. And it was always said that the acute necrotizing pancreatitis is never a one surgery, is always more than a one surgery. And first 2 to 3 weeks of the first surgery, you end up doing second and third surgery. The second surgery may be infected collection or maybe some perforation, then bleed from the superior mesenteric artery pseudoaneurysm, and patient require 2 to 3 surgery. Now with a better antibiotic, control, good all the antibiotics available, endoscopic approach available. I think the later the we approach the surgically is better and not to going. In an acute stage, nothing is demarcated. There's a loose collection, loose necrosis. So you put up a drainage tube, and there's a damage and complication due to drainage tube. The drainage tube is too much inside, or it comes out. So better to wait for 4 weeks plus or minus 1 week as per the patient's condition, and plan for a better surgery, only one surgery, and a better outcome.
Amit sir,
I'll-
Dr. Bansal, you can take over. I mean, if you're back on connection, please.
Yeah.
Thank you. Sure.
Yeah. Thank you, sir. So sorry for inconvenience. So yes, again, this article, again, a beautiful article. So regarding that, this radiological and endoscopic, good endoscopic interventions, basically modified our path. Generally, classical teaching is after 4 weeks we should intervene, but with this procedure, we intervene in prior to 4 week also, and as study, though this is a retrospective study, obviously we should do a prospective study for it, but I think this lead to more complications rather than giving advantage. So Dr. Medhu, what do you say?
Yeah, first of all, I want to tell you that I am traveling just now. I'm in the car, so there is a possibility that I may lose my signal on the way. But I just want to tell you that, as Dr. Chetan Bhatt said, that the interventional treatment of acute necrotizing pancreatitis has evolved. Initially, it was open surgery. Then people started doing laparoscopic, that is minimal access surgery for necrotizing pancreatitis. And now, more and more, we are tilting towards either a percutaneous approach or an endoscopic approach. So it's like a step-up approach. So we tend to do percutaneous, then maybe endoscopic, and then maybe keyhole or laparoscopic. And very, very rarely you require open surgical necrosectomy. Whatever it is, irrespective of all the advances in percutaneous as well as endoscopic approaches, in spite of all the endoscopic methodologies we have, not only of draining collections, but also of direct endoscopic necrosectomy through a lamps which has been placed. In spite of that, we still have reached a conclusion in multiple studies published in endoscopic articles that it is better to wait as long as possible. Because
Yes.
early intervention, even endoscopic approach, should not be done. So therefore, even though these paper which was published was showing all retrospective studies, I think the gold standard still remains that the longer you wait, the better is going to be your clinical outcome.
Yes.
Even if you are doing endoscopic or even if you are doing percutaneous, it may not be just one intervention. The interventions can become multiple. It may be recurrent. You may be able to drain some collection. Patient will settle down for some time. Then there may be some deterioration. You do again a CT scan. You'll find some collection somewhere else, which is possibly infected. There you have to drain the second collection also. So now even multi-gated approach endoscopically is coming. Percutaneous, the advantage is that you can go in different areas at the same time. So I still feel that even if we have advances, the only thing that has changed is not the timing of intervention. What has changed is the methodology of intervention. So interventions have now become minimal access, either endoscopic or radiological, less and less laparoscopic, and open. Open is very, very rarely required.
So as I rightly said, the timing is very important. Though we have multiple options nowadays, the timing weekday will be as much as possible, and obviously early intervention should not be advisable. Any other things, or we can move to another
No, I will just say one thing.
article?
Various studies have demonstrated that about 50% of pseudocysts, smaller pseudocysts, not very large pseudocysts, and also the one that is peripancreatic necrosis can resolve on a long-term follow-up without surgery. So
Exactly.
surgery is
Yes,
not
sir.
always
Yes, sir.
indicated. Even in a pseudocyst, it can spontaneously resolve, and even a peripancreatic and pancreatic necrosis can resolve without surgical approach, and it's better to wait. If the patient is hemodynamically stable, patient there is no infection, and the person is having a oral intake through NJ or through RT, I think it's better to wait. And only thing is that don't remove your NJ tube, too early if there's a large amount of necrosis.
Yes,
Don't
sir.
remove the NJ tube.
There's
So many
another point which I want to add. Another point which I want to add, that even today, in spite of knowing so much, reading the literature, having gained so much experience, people tend to start high antibiotics right from the first day of acute necrotizing pancreatitis. Now, that is the
Yes, sir.
greatest mistake, because infection sets in after 10 to 15 days. In the first 15 days, even if there is multi-organ failure, that is because of a systemic inflammatory response. It is not because of infection, even if there is
Yes, sir.
necrosis. So the infective complications happen 15 days later. But invariably, when patients are sent to us at necrotizing pancreatitis, they're already put on meropenem, right from the second day,
Yes, sir.
third day. Now, this is the biggest mistake which most of the clinicians do in practice. And then we are left with no antibiotics later on when the real time comes to give the antibiotics.
I agree
Yes,
completely,
sir.
Amit. I agree completely.
So after these two pancreatitis articles, I think we should move another test, Dr. Isma.
Yes, sir. So there's this another review article published in the International Journal of Anesthetics and Anesthesiology. This is regarding epidural anesthesia with opioids in open colorectal surgeries is not related to post-operative ileus. So as per IRA's protocols for post-operative pain relief, regional analgesia in abdominal surgeries is often recommended for early patient recovery, good pain relief, and consequent reduction in the hospital stay. So epidural analgesia is an excellent option for pain management in these surgeries. And there are a few Cochrane reviews which also they have kept early hospital discharge and recovery as the final outcome. Macklin had compared epidural analgesia with local anesthetic and opioid with IV analgesia with an opioid for the treatment of post-op pain in colorectal surgeries. So with the IV morphine, nausea and vomiting were the main adverse event. They were the main adverse effects. However, when opioids are associated with epidural analgesia with the local anesthetic, they were considered very effective and had fewer adverse effects. So the adverse length of hospital stays, return of bowel function, and tolerance to complete diet was shorter in the epidural analgesia group. But urinary retention did not differ between the groups. So epidural analgesia was a gold standard for post-op pain relief. However, the agents play a crucial role in the success of pain management and presence of adverse effects. So local anesthetics were often used, but they had a potential to cause hemodynamic instability. So to reduce these side effects and improve the analgesia, adjuvants are often added, with opioids being the most commonly used drugs. So Franzides evaluated the effects of IV, IM, and epidural morphine on the colon myoelectric activity during ileal recovery. The authors noted that morphine, when administered IV and IM, interrupts the recovery of colonic motility. However, epidural morphine did not affect the colon myoelectric activity. So they concluded by saying that opioids can be administered by a variety of routes, such as oral, IV, epidural, and intrathecal, and the adverse effects are contingent on the route in which they were administered. IV morphine increases the incidence of ileus. On the other hand, studies also showed that if used in epidural analgesia, it did not have pronounced effect on the intestine. It improves post-op pain control, decreases the hospital stay, and can be used safely in colorectal surgeries. So other studies are needed to guarantee the best route of administration for opioids, avoiding the undesirable effects on the abdominal procedures. Over to you, Dr. Bansal, sir.
Yeah. So again, one of the important article which highlighted the use of epidural opioids, uh, though it's not a typical of gastroenterology per se, but yes, yes, epidural opioids. Uh, we see in a day-to-day practice that the patient in post-operative surgery have ileus. We can reduce this by the changing the route of opioids. So, Dr. Bhatt.
Yeah, see what happens. Any open surgery, which is a major surgery or supramajor surgery, you tend to get small bowel as well as colonic, especially if the colonic surgery has been done, then even that small bowel ileus also lasting for 3 to 5 days. Most of the ileus in young people recover faster. If it persists more than 5 days, then we start thinking about differential diagnosis and everything. And the various differential diagnosis includes local infections. Then there is a probably hyponatremia, hypokalemia, hypomagnesemia, hypocalcemia, all these things, ischemia of the colon or a local site. But most important part is also painkiller, which people forget. So opioids, tramadol, tramadol, opioids are very important. In India, we don't get codeine, but abroad you get a codeine capsules. This codeine capsules produce severe constipation and dysmotility of the GI tract. So the person gets a post-operatively fecal obstruction to that extent. So I think this is a novel route. We don't practice this. This is basically comes under the pain management and anesthesiology. However, this is a very interesting article and very interesting point. So if we can do this epidural opioid analgesia, it will probably change the postoperative recovery in our major supramajor surgery cases. Over to Mehul. Mehul,
So,
any input from you?
yeah, Dr. Mehul.
Yeah. So in a lot of our post-operative patients, sir, at present, our anesthesia team, even at RFH, is regularly using, and I'm glad to say that our surgeons are happy to use epidural anesthesia. In fact, when we've got cases not only for colon but cytoreductive surgeries, which are major long duration surgeries, we bank on the use of epidural analgesia. And this paper is a good landmark paper because I had an example today itself. I've had a patient who's been on an epidural with the ropivacaine and fentanyl, and we were forced to stop the fentanyl because the patient was a bit drowsy. Subsequently, we stopped fentanyl and changed over to a plain ropivacaine. His analgesic requirements doubled. We then went back to half the dose of fentanyl, and the patient is doing fabulously well with even regards to his respiratory functions. So being an anesthesiologist, I may be having a little bias towards it, but definitely this paper shows very clearly that an epidural use of the opioid is very good, especially when you want to spare a lot of the problems with the side effects of plain lignocaine, plain bupivacaine, plain ropivacaine with regards to hemodynamic instability. And it works very well to get these patients ready to ambulate and move out fast. Amit, sir?
Yeah, see, now I will not make any comment about colorectal surgery because I've stopped doing surgery for last 35 years. But in endoscopy practice, interventional endoscopy practice, there's one area where we tend to use epidural anesthesia, and that is when we do shockwave lithotripsy for pancreatic stones. And nowadays, our protocol is to give intravenous sedation and painkillers, which could be having also opioids. However, I know there are some centers which are routinely doing only epidural uh, analgesia, especially when they do ESWL for pancreatic stones. The only issue is that passing the epidural catheter and everything prolongs the procedure time a little bit. And suppose we have 4 or 5 ESWLs in a day, the whole process becomes extremely cumbersome. So from that perspective, we feel that we still continue the intravenous sedation, and we have not found any major issues related to the bowel motility after ESWL. 1 hour, 1.5, 2 hours sometimes. So constantly the anesthetist has to keep on giving the analgesia, the opioid. It is the epidural administration of opioids may be the path forward as far as gastroenterology in ESWL is concerned.
Yes. Yes, sir. So there is definitely the role of epidural analgesia is almost nil for gastroenterologist. But yes, we found the patients of post-operative ileus routinely in our wards, and we call by uh, uh, ileus. So if the able good, they prevent the last article. This is again an important uh, aspect of on SB2 during UGI bleed. Dr. Resma.
So this we saw a case report published in Hawaii Chest 2023 regarding SB tube, Sengstaken Blackmore tube, as an effective bridge for transfer in hemodynamically unstable patients with variceal bleed. So acute GI bleed, variceal bleed is a potential life-threatening condition and requires immediate intervention. However, balloon tamponade devices are rarely used nowadays due to their association with serious complications. But there was this case report in which this patient had a massive GI bleed and who got SB tube placement as a bridge to transfer to the tertiary care center for TIPS insertion. So there was this case report showed there was this 53-year-old gentleman with a medical history of alcoholic liver cirrhosis and variceal bleed status post endoscopic band ligation. He was brought to the ED for evaluation of multiple episodes of hematemesis and melena for the last 6 hours. So on arrival to the emergency department, he was not actively bleeding, but he was hypotensive with BP of around 70/30. HB was around 3.8 with platelet count of around 64,000 and INR of 2.4. So plan was made for emergency endoscopy with possible band ligation, and hence the patient was intubated pre-procedure to protect the airway in case of massive GI bleed. But just after the introduction of the endoscope into the esophagus, he started having a massive variceal bleed. So endoscopy was aborted and massive transfusion protocol was initiated. TIPS was attempted by the interventional radiology team but was unsuccessful. So again, they re-attempted endoscopy for possible van ligation but was unsuccessful. So the patient remained hemodynamically unstable despite these multiple interventions. So finally, they inserted a SB tube as a bridge to transfer the patient to tertiary care center for TIPS insertion. The esophageal balloon of the SB tube was deflated every 12 hours to prevent complications, and the patient's bleeding significantly reduced as they observed after SBT placement and became hemodynamically stable after 72 hours and was eventually transferred to the tertiary care center for further management. So the discussion in this was that SBT tube, SBT insertion is a procedure that can help stabilize esophageal variceal bleeding. Now, until 1980s, this was a primary treatment, but later on, because of complications or what do you say, mucosal necrosis and esophageal perforation, this eventually became as a remote measure or remote treatment. So To avoid pressure necrosis, SBT was typically left in place for only 24 to 36 hours and was deflated every 12 hours. So, however, in this case, his transfer was delayed to a tertiary care center. So SBT was kept in place much longer than recommended. But surprisingly, he did not experience any significant complications while tolerating this tube for an extended period. So they just concluded by saying that SBT may be considered for an extended period of time in case of limited resources as a bridge to transfer the patient to a specialized center, but requires more data for a definitive recommendation. Over to you, Dr.
So,
Bansal, sir.
yeah. So again, this article highlighted the use of SB tube. We know that we nowadays have better endoscopic systems, so we can control better bleed. So that's why we don't require SB tube placed. But yes, few years back, this was a routine practice, and this was advisable to put a SB tube. But yes, there are complications if we don't deflate the esophageal balloon. With the advent of with the availability of wide availability of tips, and in fact the Dennis Alli stent we sometime put during the acute bleeding, in which we can't control the bleed with the bending because of so much blood. So we sometimes put Dennis Alli stent also. But yes, the SB tube have is its own role, though limited. But yes, SB tube can be placed when there is when the centers doesn't have tips facility, or in fact EVL facility, or in fact EVL cannot be possible because of conditions, poor general conditions. So we can put SB tube, yes, when the patient transfer to another center. SB tube is a very important tool in which we can control the bleeding. So SB tube again in limited role have nowadays have its significance, but yes, it can be used judiciously. So Dr. Bhatt, uh, what
I
is
will
your
let
take on this?
Amit answer this because Amit can stop any bleeding
Yeah.
anywhere. Amit, to you first.
Yeah, this is very interesting. Article SBTU published in 2020, because to tell you the truth, nowadays it's a rarity that you even need to do tips. It's a rarity that you can't stop any bleeding. In fact, I will tell you the main thing which has changed this whole thing is because of the invention of cyanoacrylate glue. It's not tips, it's not nothing else, but from the time we have started using cyanoacrylate glue endoscopically, there is no value which you cannot stop. 25 years back, I wrote a book chapter in a textbook which was called Non-Responders in Gastroenterology. And the name of the chapter was Treatment of Acutely Bleeding Varices which are recalcitrant to endotherapy. And conclusion of my chapter was that there is no acute bleeding varices which is recalcitrant to endotherapy. Why? Because invariably any variceal bleed can be stopped by cyanoacrylate glue. Now let me tell you one thing. There's only one issue here, that if the physician is practicing in an area where they don't have any facility whatsoever, but they have to save the patient's life because the bleeding is so massive that something they have to do.
Now, see, for everyone here, recently we wanted a Sengstaken Blackmore tube in our hospital some time ago, and we did not have the tube in our hospital. And we were struggling to get this tube, and we had to really struggle to get this tube in our tertiary care center. Now, one must remember that Sengstaken Blackmore tube was the most original tube which was devised. After that, a tube came which is called as a Minnesota tube, which is quadriluminar. Sengstaken tube is a triluminar. And after that, the latest tube was Linton-Nicholas tube, Linton-Nicholas tube, which is a single balloon, large gastric balloon tube. Now, what is this thing, The the varices bleed at G junction. They do not bleed higher up in the esophagus. So you don't need the esophageal balloon, number one. Number two, if you do a good tamponade at a G junction, gastroesophageal junction with a large balloon, the Linton necklace tube is 500 ml, whereas Sangstekel Blackmore tube, the gastric balloon is about 200 to 250 ml. Esophageal balloon is 80 ml. So even if you distend only the gastric balloon, majority of the junctional varices and esophageal varices you can block. Esophageal varices start from the stomach and enter the esophagus, and they are most dominant at G junction. However, I have not used Sangstekel Blackmore tube for more than 30 years. Last probably I used was in 89, 90. After that, I have not used because of the better endoscopes, better technique, and better collective team available for the endoscopic procedure, and also the Turley pressing. The low dose Turley pressing is very effective even in controlling bleeding. Now, second point I will tell you about Sangstekel Blackmore tube. Where do you pass from, mouth or nose? The answer is nose and mouth both. If you put it from the mouth, how do you apply traction? You have to apply traction at G junction. So how do you apply the traction when you put it from the mouth? So you apply a weight, about 300 to 400 grams of weight you apply. If you put it through nose, we had done a very indigenous thing in KEM hospital when we were gastroenterology department, we were lecturer. We used to cut a tennis ball, table tennis ball. We used to cut it half, put a Sangstekel Blackmore tube in the outside the nose part in that tube, and put a sticking plaster over that and create a tamponade there. Complications, you get an ulcer, necrosis, and ischemia of the nasal cartilage. You also get a probably tear at the G junction. You get a ischemia of the esophagus, ischemia and rupture of the esophagus, various complications. And most importantly, any secretions above the level of esophagus, person is to aspirate. So the Minnesota tube came in. There was a fourth lumen above the esophageal balloon for the aspirations. So now, if you have a Sangstekel Blackmore tube or a Linton necklace tube, you don't have to inflate the esophageal balloon. Inflate the gastric balloon, apply a good tamponade, start Turley pressure, you can shift this. This is only for the remote places where there is no endoscope available and nothing available. But if you have the endoscope available, expertise available, a good endoscopic department you available, I think the endoscopy should be the first choice. I would say that.
So as the time is exceeding, and obviously we will have to close this session.